Welcome to Pulse and Pressors, where critical care gets crystal clear. Epinephrine is a powerful mixed alpha and beta agonist used as first-line therapy in cardiac arrest and anaphylaxis, and as a second-line vasopressor in refractory shock. Its potency makes it effective, but also high risk, so it requires disciplined dosing and monitoring. It is an endogenous catecholamine that activates alpha 1, alpha 2, beta 1, and beta 2 receptors, with receptor balance shifting as the dose rises. Rapid metabolism by COMT and MAO into inactive metabolites gives it a short half-life and allows quick titration. At low doses, beta effects dominate, increasing contractility, heart rate, and bronchodilation. At higher doses, alpha vasoconstriction becomes predominant. Epinephrine increases cardiac output, heart rate, SVR, and has predictable metabolic effects such as hyperglycemia and lactic acidosis via beta 2 stimulation. Epinephrine is indicated in ACLS cardiac arrest, in anaphylaxis as the first-line drug, in refractory septic shock after norepinephrine and vasopressin, in cardiogenic shock with low cardiac output, in severe refractory bronchospasm, and in post-cardiac surgery low-output scenarios. Its main therapeutic advantages are rapid restoration of circulation in arrest, immediate bronchodilation, and hemodynamic stabilization in anaphylaxis, and strong inotropic rescue when other pressors fail. It also augments coronary and cerebral perfusion pressure during low-flow states. Cardiac arrest dosing is 1 mg IV push every 3 to 5 minutes using 1 to 10,000 concentration. For anaphylaxis, 0.3 to 0.5 milligrams intramuscular using 1 to 1,000 is preferred, with intravenous 1 to 10,000 reserved for life-threatening shock. ICU infusions typically start at 0.01 to 0.05 micrograms per kilogram per minute and may be titrated up to 0.5 micrograms per kilogram per minute in refractory cases. Pediatric use is strictly weight-based and capped at lower maximum rates. Epinephrine sharply increases heart rate and contractility, raising blood pressure and cardiac output, but also myocardial oxygen demand. At higher doses, splanchnic and renal vasoconstriction can compromise organ perfusion, while metabolic changes include hyperglycemia, hypokalemia, and lactic acidosis. Adverse effects are dominated by tachyarrhythmias, myocardial ischemia, and severe hypertension. Type B lactic acidosis from beta 2 activity is common. Peripheral and visceral ischemia, hyperglycemia, hypokalemia, and pulmonary edema from increased afterload and preload are important risks. It should be used very cautiously in patients with severe PVD or Raynaud's. Hemodynamically, epinephrine produces large increases in cardiac output and heart rate, and, at higher doses, SVR. Coronary and cerebral flow may improve, but splanchnic and renal flow can worsen. Because myocardial oxygen consumption is very high, prolonged use is hazardous in ischemic cardiomyopathy. Compared with norepinephrine and dobutamine, epinephrine has the highest myocardial oxygen demand and arrhythmia risk, and uniquely drives beta 2-mediated lactate elevation. Norepinephrine is first line for septic shock. Dobutamine is favored for cardiogenic shock with preserved MAP. Epinephrine is reserved for low cardiac output or refractory shock after norepinephrine and vasopressin have been optimized. Versus dopamine, epinephrine provides more reliable inotropy and vasoconstriction. Dopamine's variable receptor profile, higher arrhythmia burden, and worse outcomes have led to its decline. For refractory cardiogenic shock, post-arrest support, and anaphylaxis, epinephrine is clearly superior, and dopamine has essentially no role. In septic shock, epinephrine is a second-line adjunct after norepinephrine plus vasopressin. It is used when hypotension or low cardiac output persists despite adequate fluids and first-line pressors. Rising lactate in this setting often reflects type B lactic acidosis rather than worsening hypoperfusion, so it must be interpreted with the clinical picture. Epinephrine should be weaned early once perfusion is adequate. In cardiogenic shock, epinephrine can temporarily restore forward flow when both MAP and cardiac output are severely depressed. However, the increased oxygen demand can precipitate ischemia, especially in ACS. It often serves as a short bridge to MCS. Once blood pressure is adequate, I-no-dilators like dobutamine or milrinone are generally safer for sustained support. In mechanically ventilated patients, epinephrine's tachycardia can worsen dysynchrony and oxygen consumption. While beta-2 bronchodilation helps in severe bronchospasm, increased afterload and capillary pressures can promote pulmonary edema. In ARDS, the increased oxygen demand and potential VQ changes make epinephrine a less desirable long-term choice. On ECMO, Impella, and intra-aortic balloon pump, epinephrine's tachycardia reduces diastolic filling and can worsen LV distension, particularly on VA ECMO. The goal is to use the lowest effective dose for the shortest time and transition to norepinephrine or I-no dilators once perfusion is more stable. In cardiac arrest, epinephrine is administered as 1 mg IV every 3 to 5 minutes. It increases coronary perfusion pressure and improves ROC, but has not shown clear benefit for long-term survival or neurologic outcomes. High-dose strategies were abandoned due to increased harm. After ROSC, low-dose infusion can be used to support hypotensive patients. For anaphylaxis, intramuscular epinephrine 0.3 to 0.5 mg of 1 to 1,000 is the critical first move and can be repeated every 5 to 15 minutes. IV 1 to 10,000 dosing is reserved for patients in extremis and must be given carefully. Timely epinephrine reverses airway edema, bronchospasm, and vasodilation. Delayed administration is strongly associated with worse outcomes. Type B lactic acidosis from epinephrine is a pharmacologic effect, not necessarily a marker of failing resuscitation. Lactate must be interpreted alongside perfusion markers such as urine output, mental status, skin perfusion, and venous oxygen saturation. A lactate rise alone does not require more pressors if perfusion is clearly adequate. Epinephrine infusions are prepared at 1 to 4 mg in 250 milliliters and run on a pump. Central access is strongly preferred because peripheral administration carries a high risk of extravasation and necrosis. If extravasation occurs, phentolamine should be infiltrated promptly. When the patient stabilizes, epinephrine is often the first vasopressor to be weaned due to its high MVO2 burden and arrhythmogenic potential. Monitoring must include continuous telemetry, an arterial line, and frequent assessment of lactate, glucose, and peripheral perfusion. ECG monitoring for ischemia and, when available, cardiac output monitoring help ensure the benefits of epinephrine outweigh its risks. This is Pulse and Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.